Ding, tick a ding, ding, ding. Ding, tick a ding, 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 ding.
Hi, I'm John,
And I'm Christine.
and we're going to discuss evidence-based practice, herding ICU sacred cows out to pasture.
What? I'm going out to pasture? Oh, hey, Joe. How's it going? Oh, hi, Mo. Well, these are our cows, and they're going to be joining us today as we talk about evidence-based practice in the ICU.
So evidence-based practice is imperative for providing the highest quality patient care, although only 30 to 40% of patients receive care based on evidence-based practice.
Let's get going.
Sure, so the first thing we'll discuss is the Trendelenburg position and its use in treating patients with hypotension.
Oh, hypotension.
Yeah, been a pretty pervasive practice for ICUs to treat patients with hypertension with the Trendelenburg position, which is essentially making their head recline by 45 degrees.
Oh.
Yeah. However, contrary to belief, it does not improve blood pressure or cardiac index, and it has potential for reducing ventilation and can increase risk for aspiration.
Oh, well, why do they do it then?
That's a good question. It's just, there's no evidence to support it. I think it's just more tradition.
So, what do we do instead?
That's a good question. Really, there is no positioning alternative that drastically improves, blood pressure in patients with hypertension. That's going to require alternative medical interventions. Fecal incontinence and the use of rectal tubes. Now, what that means is, people that do not have the capacity to control their bowel movements are at risk for perennial skin damage. And one strategy that's been used in the ICUs has been the use of rectal tubes, which is essentially a tube that's inserted into the rectum that collects the feces.
That's interesting.
Yeah. Unfortunately, it's not substantiated by evidence, and it poses potential problems.
Oh.
Yeah, there's risk for damage to the anal sphincter and the colon mucosa. Now, alternatively, what's recommended is the use of a rectal bag or a rectal collector. And that is more advantageous because it's an external bag that adheres to the skin, and it's not as invasive because it doesn't enter the body.
What's this I hear about gastric residual volume and aspiration risk?
Well, in patients receiving feeding via, say, a nasogastric tube, it's really or a G tube even, excuse me. It's really common for the assessment of residual volume for food contents that have not been thoroughly assimilated and digested. Well, it's been thought that that contributes to aspiration risk, when in fact it's more indicative of malabsorption and a poor response to the feeding. Yeah, so in reality, the best way to reduce aspiration risk in patients receiving feeding is to, one, assess placement of the tube. So that would be, chest radiograph. And additionally, you want to do some other precautions, such as, you want to elevate the bed, the head of the bed 30 to 45 degrees. You really want to, continually reevaluate the need for the tube and evaluate if continuous feeding is preferable, amongst other things. So the next thing we'll discuss is restricted visiting policies.
Oh, I think I've heard a little bit about this.
Yeah, well, traditionally, restrictions have been placed on guest visits. The thought was that having too many people around at various time frames provide too large of a stressor for the patient and can compromise the care.
Well, does it?
Well, contrary to that thought, evidence suggests that, in fact, patients prefer to have extended visiting hours rather than restricted visiting hours, because patients report that having, say, close family or friends is soothing to them. There's a calming effect there. The patient's guests can facilitate communication between the healthcare providers and nursing staff and the patient. And overall, the the guest can help facilitate, or I should say, promote the best course of treatment.
Oh. Well, I hope all my cows can be by my bedside when I'm in the hospital.
Well, yeah, if you have a big family, the more the merrier, right?
So I'm going to talk a little bit about cell phone use in the critical care areas. So while 95% of hospital personnel believe that it's really important to have their cell phone with them at all times, there's been a ban in ICU units because they think that there could be electromagnetic interference with the complex ICU equipment. And so, maybe the data is being thrown off because of this electromagnetic interference. Well, hey, Mo.
Hey, I heard about that electromagnetic interference.
Oh, you did?
Oh,
Well,
yeah.
Well, did you know that the interference is only a concern if you're within a 100 centimeter radius of the device? So that's actually a really small area. So the AACN is just recommending the 1 meter rule. So patients, family, and staff can have their cell phones with them at all times, and the phone just needs to be a meter away.
Wait, that's real good to know, Christine, because I love my cell phone.
Oh,
Excuse me,
hey,
I got a call.
I didn't know
Excuse
cows
me.
had phones these days.
Oh, yeah. Facebook, Twitter, hit me up.
So, oxygen administration in COPD patients. A little bit about that on the history. Oxygen administration has always been given with caution in COPD patients because they think that it can blunt the hypoxemic drive of the patients to breathe. However, if you're withholding oxygen from these patients, it can cause hypoxia and even organ failure. So it's pretty bad.
That's bad, right? I think that's bad.
That's bad. So best practice, we're going to advocate for the administration of oxygen to patients who have COPD with acute exacerbations with a PaO2 of less than 55 or an O2 sat below 88. And we should not withhold mechanical ventilation from COPD patients either because it gives their respiratory muscles rest. The next topic is normal saline instillation before endotracheal tube suctioning. So it was always common practice that normal saline was instilled before suctioning because it was believed that that the saline could loosen secretions.
It makes sense to me.
Yeah, right? I would think so too. And, it was thought to improve oxygenation. But lo and behold, studies show that it actually does not improve oxygenation. And actually, people who had normal saline instilled, when they pulled out the ET tubes, there were 5 times the bacteria of people who hadn't had any normal saline in there. So you don't want bacteria down there. That's your lungs. You want it to be clean. So, yeah, even cows know that. So,
Hey, what's that supposed to mean?
sorry, Mo. So we should not instill normal saline before ET tube suctioning. And if the secretions are thick, we want to just do oral or parenteral hydration. And so our last topic is confirming placement of nasogastric tubes. And the common hospital method for determining proper placement has been a lot of nurses will do the pH testing of the aspirate. They might visually inspect it, or they'll listen or auscultate when they're putting in the air, or they'll do carbon dioxide capnography. However, studies have shown that these are actually not reliable methods of proper NG tube placement, and it's really important to get the NG tube in the right place because there's a risk of aspiration pneumonia and the sequelae that come with that. So best practice is we want to do a chest x-ray before any use of the NG tube. And that's our show. So thanks, Mo, for being with us.
Thank you.
And thanks, Joe. Hey, it was good being here. I learned a lot. Well, that's great. I'm glad you did. So thanks, guys. And
Thank you. Yeah, that's it.
say la vie.
Say la vie. Say it's cool. That's the drugs.
Ding, tick-a-ding, ding, ding.